Starting the Symposium on Artificial Intelligence. You all know that this is the buzzword now. And for the next few minutes, I wish to give an overview on artificial intelligence in microbiology and other than microbiology in the clinical medicine, and how it adds value to the patient care, its value to the laboratory diagnosis and surveillance. So you all know that artificial intelligence is almost machine learning, and one subset of the machine learning comes under the artificial intelligence. Machine learning is nothing but like we teach our kids from LKG, UKG, 10th standard, 11th standard, then college specialization, something like that. You need to do the machine. You need to educate the machine. And deep learning is something like you are giving a coaching to the Indian Institute of Technology, IIT entrance exam, something like that, much advanced. And the teaching includes language, visual, then voice recognition, and need to integrate that one. So these are all the components of artificial intelligence, mainly the machine learning and the deep learning with algorithm based. So how does machine learning works? So you need to educate the machine. Suppose I have given some pictures. You can see if it is a flight aeroplane, all types of aeroplane variant in different shapes, size, models, functions, birds, animal, human, you name anything in multiples and hundreds, you have to keep educating. The more you educate the machine, the more very good output you are going to get. So the secret of machine learning to be very successful is how much of a knowledge you are doing to the machine. So what you need to do is you have to label everything, and this need to be integrated, and then it recognizes and it interprets the data. So this is how it works in a simple terms I have said. And the important thing for any machine learning is the data. So if you give very good data, it's going to give you very good output. So garbage in, garbage out, they call it as. So data is the most important thing for any machine learning. As the data scientist Edward Deming put it, without the data, you are just another person with an opinion. So look at this one. What is the requirement for powerful machine learning? Again, as I mentioned to you, data, data, data. And the amount of data, the more the better the quality, context and interconnectedness are very important. And yesterday also the student symposium people mentioned about the FAIR principle. It should include findable, accessible, interoperable and reusable informations. And for this data to store and operate, we require high performance computers. And to store the data, look at the way it has evolved over years. Earlier, a few years back, it costed 1 GB data to store $12. Now, less than 0.15 cents it requires, and a lot of data is there now in the public database, and China is leading. And the US is much lesser than China, Europe is much lesser than China, and next comes the Japan. So it's very important. If we want to have a useful AI application for ourselves, then we need to contribute to the data. Either you share with them, or you need to create on your own and you have to maintain. Without sharing and having a collective data, then AI is not going to work anywhere. And look at this. Here, earlier in 1950s, the computer looked like that. Now, in a desktop, the way it has evolved is 1 billion times. And the data we have is almost from 100 billion, we are moving to 1 trillion. And now I come to the microbiology aspect of artificial intelligence. In our day-to-day routine practice, what we do is, from the specimen, we do the microscopy, culture, molecule of identification, then E-test or MIC we do, or we move to the molecular aspect. Either you do PCR or whole genome sequencing. So now I will give one example of culture, how the culture is interpreted using the artificial intelligence. Look at this one. Here, the artificial intelligence, the culture, colonies are exposed to the microscopy. Like a PET scan, the artificial intelligence makes multiple sections of the colony, its surface, edge, color, shape, everything it captures, and then it interprets the colony. And what is the success of this? You look at this one, detection of colonies, whether growth is there or not, almost 90% concurrence is there. Then look at their primary, the two organisms, Staph aureus and E. coli, and it has correctly identified more than 95% of the time as a Staph aureus, and the E. coli also it has correctly identified as more than 95%. So even though it's beginning now, and definitely down the years, you are going to have this question as a standard of practice in any of the laboratory. Now I move on to the customized GPT as an expert. GPT is going to help us. Can you imagine this one? This is the best example I can show you. You can look at the susceptibility plate and they can measure the zone of inhibition. And this OpenAI has been taught and this has been recognized and people from the UCAST are working on it. So what they have done is they exposed to this plate to read the zone of inhibition and based on their interpretative criteria. Exactly in the step 4 you can see it has taken the measurement and it has given the interpretation. It's all automated. And then one step higher they have gone and they asked to interpret about the ESBL, AMPC and carbapenemase. Again it has interpreted. I would like to show the. So look at this one. This is the human expert has done for ESBL, AMPC, carbapenemase. Almost 100% human can do that one. How the chat GPT has done, you look at this one. So chat GPT, sensitivity for specificity for all are almost 100%. Sensitivity for carbapenemase 100%, whereas for AMPC 86%, ESBL almost 70%. They are very close. In another few years, definitely ChatGPT can do excellent interpretation of the AST. So this is the way we are moving forward. So look at this one. Don't underestimate ChatGPT. Look at the one person came and submitted to the ChatGPT small miniature stool, put it into a collection box, specimen collection box, and asked them to interpret. The ChatGPT correctly interpreted, saying that you are making fun of me. It's a sample collection tube with a miniature stool. So it's besides the fun, please submit original specimen it has told. So that much of education and understanding ChatGPT has got now. And AI becomes more advanced, many human tasks might become redundant. What will people do when machines are better than human? Definitely, without error means even ourselves will move to the machine, but definitely challenges remain. And for advanced of technology, definitely AI transformed into language transition, recognition of the speech and the image. So technology is there, but only problem is it has not advanced in the medicine. Driverless car driving is there. The rocket gets launched and comes back and gets into the pedestal automatically, but in medicine we have not achieved that much. The reason is complex and dimensionality of the data, and the rare signals has to be included, regulatory has to be written, expertise is needed, and business model has to be there. This is the hindrance for one. And now AI has the potential to do enormous good to solving in clinical medicine and in clinical microbiology laboratory. I will just quickly say about what it does in clinical medicine. Radiology, the mammogram with the Google DeepMind, Watson Health can get accuracy of this one. Lung disease again it can do. Again in ophthalmology it can do wonders in Google DeepMind, and accuracy is that one, it is FDA approved. Then similarly in cardiology it can pick up the atrial fibrillation. In neurology it can pick up the stroke, and in oncology it can pick up the cancers with these tools and with that accuracy. So this is the way it is moving forward. Dermatology, again cancers can be picked up. Then genomics, precision medicine, again it does well. Gastroenterology, again it is FDA approved GI Genesis. Then moving on to the infectious disease, Sepsis it can pick up, schizophrenia it can pick up. So lots have been done and many tools have been FDA approved. Look at this one. These are all the tools which has been FDA approved. One is dermosensor. Skin cancers also can be picked up with high accuracy. Then atrial fibrillation can be done with high accuracy. Then chronic conditions can be picked up because high accuracy and the tools are readily available and FDA has approved all these tools. And prostate cancer can be picked up very quickly. And sepsis score again FDA approved. So many tools are available in the market now. And moving on to the microbiology, what is there? Fecal ova and cyst can be picked up parasitology within 30 seconds with high accuracy. So anything you focus on parasitology, it will pick up with greater accuracy. Then this is the picture. It becomes much easier. And then we don't have the ability to predict the porine and efflux. Again, it is comparing the wild data, type data, and the patient resistant data. It can pick up the porine and the Pseudomonas aeruginosa. So looking at various mutations, stop codon, friendship mutations, everything it recognizes, gives the interpretation. Then look at the next one is tool and software which are available freely in the net, which you can use is this explainable AI is for the fungal infection diagnosis. Google lab something like a Google Sheet. You can use it for any surveillance. And multimodal AI, these are all for the medical purpose. These tools are available freely. Now, the last component of my overview is, do we lose job due to the artificial intelligence? I will let you, if you don't know have the artificial intelligence, the data science, then definitely you become a little useless in front of the knowing people as an elite. So workforce realignment, the people who are doing microscopy in the higher centers, definitely the machine is going to do with much more accuracy than human. Again, plate reading, machine will take over. Then repetitive analytic work, machine will take over. Then whoever does the errand work, most of it will be done by the machine. And even automated reporting, it will be taken over by this one. So how people has to respond and prepare themselves to work here is multiple things they need to understand. What is microbiology and data science to be AI system management, then AI training and development for disciplinary and microbiology expert. Clinical support system is another area where respective clinicians and the laboratory has to go hand in hand. So this is how many new area opportunities are opening up, and the old will disappear and the new one will come in. So with that, I would like to introduce Dr. Pragya. She is from AIIMS Raipur, and she will be talking about the lab diagnosis. And Dr. Archa from GMC Bhopal. She will talk about the infection prevention and outbreak. Then Rahul, he will speak on antimicrobial stewardship. He is from AIIMS Bibinagar. And then Dr. Priyadarshini from St. John's Hospital. She will talk about the fungal infections. And Shripad want to share his experience of developing a tool for rapid test. At the end, this is my team which worked for us. And he is the admin who heads the UCAST AII committee. And he wished to be happy if we invited to be here for the next conference. And we work with them in this area. With that, I would like to end and invite one after the other 4 speakers to do whatever they have done on their topics. Please, Dr. Pragya, can you
Good morning, one and all. With the very apt introduction, we know that today we are at a juncture of two very powerful forces. The two forces are artificial intelligence and microbial diagnostics, which is in its full glory. And these two powerful forces have come ahead at a crossroads where they want to join hands to combat the battle of antimicrobial resistance. In my presentation, I will be talking about how AI has a power to impact microbial diagnostics, the different aspects of diagnostics, and how AI can help us in battling AMR. We are all aware of the challenges that the conventional diagnostic techniques in microbiology are faced with. Be it the long turnaround times, be it the lack of skilled personnel, be it the inter-observer variation or subjectivity of certain tests, be it the cost. AI has transformed industries, and today it is revolutionizing how we can detect, diagnose, and combat infectious diseases. The progress made in AI, especially in the fields of machine and deep learning, has greatly contributed to the diagnosis of infectious diseases by impacting microscopy, by revolutionizing culture plate readings and colony countings, antimicrobial susceptibility testing. There are a lot of applications which I will be talking about, and ultimately detection and characterization of infectious diseases is going to another level with AI in place. An introduction has already been given, but then for the newer audience which has walked in, artificial intelligence is the broader concept of machines being able to do the tasks that normally require human intelligence. Machine learning is a subset of AI where we program computers, and those computers, because of the feeding which is done into them, are able to take complex decisions, which may be decision making, which may be identification of patterns. Deep learning, which will be often referred to in today's symposium, is another subset of machine learning, which is called deep because there are multiple neural layers. So it is modeled after the human brain. It works on something called artificial neural network. So this is how your machine learning works, a deep learning specifically. A lot of images of dogs has been fed into the model that we want to look at, and when that model is run through another image, which may be a dog or a cat, it goes through different layers and ultimately a decision is given. And this has immense applications in clinical diagnostics and in fact revolutionizing the entire microbiology. So the first topic which I will be dealing with is how AI has the power to enhance microscopic techniques. Now, microscopic techniques, as Sir said, is one of those areas of microbiology which is the most operator dependent, which is the most subjective, most time consuming activity in the laboratory. A deep learning model has different layers which have been fed with different microscopic images of microorganisms, and depending upon geometric characteristics at that microscopic level, they have the ability to identify microorganisms for certain organisms, and they have the ability to group microorganisms into different groups. So this is what we encash upon. This highly quoted paper by Smith and Kirby, they initially started with a convoluted neural network called Inception 3.0, which they developed to identify day-to-day images of day-to-day things. So they finally modeled the outermost layer of that particular model to identify organisms, bacteria as such, and to group them into various groups. So this platform can look at a smear and it can identify whether you have a gram-positive cocci, which is in groups or in clusters, or gram-negative bacilli or gram-negative cocci. And the result which it gives is a probabilistic report of a gram stain with a probability percentage of what the organism could be. This has been studied on positive blood culture bottles as well, so it would be worthwhile to have positive blood culture bottles being seen by an AI platform. A Metaphor platform is one of the platforms which has been developed, which would give out a report of the type which we manually get. And this has been tested across a lot of samples. Now this particular study has taken microscopy to altogether different level. What they have done in this study is, for identification of organisms per se, they have used something called a hyperspectral technology, where they have imaged organisms using a wider wavelength to a finer resolution, to a finer spectrum than the normal spectrum, and then this image can ultimately, it runs through an AI platform which ultimately identifies the bacteria as such. So after staining, data cubes are generated. It is called a cube because it is a three-dimensional data which they have taken to an artificial intelligence model called BufferNet, and this BufferNet ultimately gives you the, it measures the spectral details, generates a heat map of the bacteria, and in as less as 30 seconds you have the identification with you. This test, this platform has been validated for 11 genera in this particular study, and it needs more validation of course, but then this can serve to, ultimately rule out the cultivation time for bacteria altogether. And they tested a lot of modules. This particular module called BufferNet has a impressive precision. The second major type of image-based automation, which we talk about in microbiology, is reading of culture plates. In contrast to the slide-based automation, which is still in its infancy, image-based automation is very much in place. There are systems which are there. This actually clever culture system by Thermo Fisher, which is marketed in US and in Europe, is FDA approved, has CE licensing. And there's this system called APAS system, which means automated plate assessment system, where you can just load your culture plates and it does the entire reading for you. Has a very good throughput. You can read, means the machine is able to read 200 culture plates per hour. You can just load the plates and walk away from the system. It can very intelligently segregate the plates into those with no growth, those with a non-significant growth, those with a significant growth, and those which need a review at a later stage. They have different modules. Most commonly, automation has been done in urine cultures. Then we have a lot of systems which can do automated urine culture. No growths can be released in an hour. With AI empowerment, these systems become even smarter. They have infection control modules, especially for MDRO surveillance, MRSA and DRE, and even manual zone size reading can be done for AST using this clever culture systems. Wakad, based in Italy, is a leader in full lab automation in microbiology. So it has an entire full lab automated systems where you have started from your sample sorting, sample processing, you have a walkaway specimen processor. So they have this AI system which is called Phenomatrix, and then there's an advanced version called Phenomatrix Stack, which is an AI enhanced software for reading of culture plates. So as Sir showed, the colonies can be read. And it also, just like the previous system, the clever system, it also can put plates by the kind of growth it has, and it can sort it out, and you can set your own rules, the lab rules can be applied, and the results can be directly exported to the LIS. It also has different modules. You have modules for your urine culture, you have these surveillance modules where it picks up MRSA, DRE, and Group B streptococci on a chromogenic agar. So most of these systems work on a chromogenic agar for these MDRO surveillance. And you also have an advanced system where you can tag, which is called Phenomatrix Tag, where you can tag your colonies which need further processing and which need ID-AST. It has a lot of advantages, as we already know. The turnaround times improves drastically, and you can focus on the plates with interest. The no growth can be reported as such without wasting any human time. In fact, BD also has a platform called Kiestra, which is a deep convoluted neural network based model that captures images of urine samples for culture analysis. TipTop, as we all know, has really served to revolutionize identification of bacteria and fungi. There are some inherent problems associated with TipTop when the sample processing is not very appropriate. The spectrum which is generated, the mass spectra or the fingerprint, can sometimes be suboptimal. When you use AI for it, AI can maximally exploit the data which is embedded in the spectrum. Even the peaks which are not optimal, even the suboptimal peaks can be captured by AI. It can pick up minor variations. You can set up algorithms for identification of even subspecies. Has been tried for some coagulase negative staphylococci. It can handle data in multiple dimensions, and it has a role in identification of phenotypic AST. Antimicrobial susceptibility testing can also be done using Matidoc when you employ AI technologies with it. So, point of care diagnostics have totally revolutionized how microbiology works, and using AI, just like Sir said, we can pick up parasites. You have detection modules for parasitic ova, you have detection modules for malaria where infected RBCs can be identified very quickly in as early as 30 seconds. Trichomonas vaginalis infection, you have cell phone based AI technologies which can diagnose diseases like syphilis, like HIV. There are studies which have explored a lot of infectious diseases which can be diagnosed in these manners, and AI is really here to empower us. So this was the role of AI in microbial diagnostics, specifically bacterial diagnostics. I move on to the second part of my presentation, which is the role of AI in battling our common enemy, which is AMR. Image processing is one of the cardinal features of AI in microbiology. Image processing for AI can help read culture plates. It minimizes all the human errors that can occur by culture plate readings. So the culture plate reading is taken by the system. It captures images depending upon the depth of the color. The zone sizes are measured. The AI cloud, which is linked with it, needs to be paired with the rules, the expert rules that you have set for your laboratory and those of the standards. And such a spectrum can be generated, and ultimately you get your antimicrobial susceptibility testing. Now, going to the next level of AST, something called single cell phenotyping has been validated for rapid AST. Now, what is single cell phenotyping? This very interesting and elegant study which was done at the Oxford University. What they have done is they have treated bacterial cells with antibiotics. When you treat bacterial cells with antibiotics, changes happen in the chromosome. And these changes are very specific for each antibacterial and each bacteria. Now this has to be fed into the trained model, and then when you expose this trained model to unknown bacteria, it can sort of, by microscopy of that particular cell, it will tell you whether it is resistant or sensitive. So these images are images of untreated bacteria and bacteria which have been treated with high concentrations of drugs. Like 4 drugs were tested in this particular study. An unknown sample was taken. The model was trained by feeding into it a lot of micrographs, a lot of images of treated and untreated bacteria with antibiotics. And when this computational pipeline is trained on these photographs, it now knows and it can on an image identify whether the bacteria is sensitive or resistant. So ciprofloxacin, gentamicin, rifampicin and co-amoxiclav were studied against E. coli isolates, and susceptible or resistance was detected. And when we want to compare this method to a standard AST, this single cell phenotyping, which is nothing but microscopy of individual bacteria, can give you results as quickly as 30 minutes as compared to your growth assay which we routinely perform, which takes 24 hours. So this is quite impressive, but it needs validation on more bacteria against more antibiotics before we get a form that can be generalized and used in practice, but sounds very promising. Again, we have AI-based point of care tests for detection of MDROs. We have mobile apps which can help fight AMR. So a mobile can be used to take pictures of the keyboard distribution plates, and those images can be interpreted. The rules can be fed into it. It is linked to a cloud which has an AI software, and this rules out the interoperator variability. It accounts for all the errors that can happen on a manual examination. And this particular system was found to have a 90% agreement against a hospital standard automatic system and 98%, which is quite good, against manual measure. Similarly, these authors, they have developed a point of care test for detection of MDROs. Now this point of care test has three components altogether. It has a fluorogenic probe-based detection assay which picks up beta-lactamases. Then it has a microfluidics-based sensor, and ultimately, via the aid of a mobile phone, it is linked to an AI cloud. Now, what is the job of this AI cloud? This AI cloud is the intelligent system which is built in there, which can calibrate the temperature and pH, and it allows to take care of all the manual errors that can happen, and not only the presence or absence of beta-lactamase. It can even quantify beta-lactamases in these bacteria. Has been tried for Staph aureus. It was tested against nitrosamine and has been tried for E. coli and different types of samples like serum, sewage and saliva have been tested. So these are all promising technologies. There are a couple of studies which have tried to explore how genomic sequencing data can be coupled with AI for the prediction of drug resistance in different bacterial pathogens. This has a specific benefit for organisms that are difficult to grow or culture, like Mycobacterium tuberculosis. For users who are not very friendly with bioinformatics, there is this platform called AMR Collab, which with limited bioinformatics knowledge also you can work on it. You can analyze, compare and visualize the trends in AMR pathogens easily. Similarly, there is this deep neural network based model called ARGNet, which is way better than the conventional models, because the conventional models which we have, they rely on detection of mutations based on sequence alignment. So the problem which happens is many novel IRGs can be missed, but ARGNet is a flexible, efficient model which is applicable in both target sequencing as well as metagenomic sequencing. So lastly, I also want to tell that AI has been explored for its role in drug discovery and drug repurposing. Deep learning approaches have been used and they have aided in exploring newer chemical spaces and those spaces which can serve as targets for newer antimicrobials. AI has been used to develop newer beta-lactamase inhibitors and to theoretically check the efficiency of these drugs using the modeling platforms. So with this, I would like to end. My take homes are AI drastically reduces the time to diagnosis, and with AI we should be able to tap AI to make the maximum benefit out of it, so that we are able to lead faster and accurate microbial identification. And AI is here to help us determine AST in as less as 30 minutes, which is very exciting promise that AI is giving us. And we must not feel threatened. AI is not here to replace us. AI is here to help us. And the key is a collaboration between microbiologists, bioinformaticians, and AI developers. So AI works on, like Sir said, AI works on memory. So the more information which we feel, the more powerful it becomes. It knows how to modify itself. Thank you. I thank Balaji sir for helping us out through this, and thank you for giving me this opportunity.
Thank you, Pragya. And now next I call upon Dr. Archa Sharma from JMC Bhopal to talk on infection prevention and control and the AI. Pragya, you need to come and speak. Pragya, here. She's from Bhopal.
A very good morning to the esteemed audience present here today. After the wonderful introduction by Sir and Dr. Pragya taking us through how we can use AI in our lab, I'm here for a wake-up call for all our hospital infection control officers who work tirelessly day and night. I call it selfless work because all their hard work improves patient outcomes and it helps the patient get out of the hospital faster. all infection control managers and teams, we have the next frontier for AI, which is I'm going to talk about how infection control and machine learning, they help us revolutionize our infection control by revolutionizing hand hygiene practices and by helping us doing predictive surveillance of the common HAIs. All of us know that the healthcare associated infections are rising, their prevalence is alarming, the antibiotic resistance is rising, and they have diverse transmission. At this forefront, our microbiologists and infection control officers have the traditional surveillance methods which use manual surveillance, lot of data, putting the data together, getting the statistics out and helping the patient. So to overcome this, at a forefront, we have to be at our best, and we have a few AI practices that can help us achieve better. I will now start with transforming hand hygiene practices. So when we talk about hand hygiene, the single most important step of infection control, all of us would agree is hand hygiene. The better the hand hygiene, the better the patient outcome. So when we use AI in hand hygiene, we can do real-time monitoring. There is automated feedback and instantaneous and personalized reports can be generated. The data is data-driven insights, the compliance tracking, and you can also identify high-risk areas. Our healthcare workers can be incentivized by a little bit of gamification, by giving them instant feedback and giving out awards for the best performing wards and best performing areas of the hospital. And we can also do predictive analysis to see where we are expecting to have an outbreak. All this improves patient safety, patient efficiency, and training. Now, how this hand hygiene monitoring works? So basically, like Sir said, there is someone always looking at you, and that's possible now because we have placed cameras, diodes, sensors, or a dynamic model which combines any of these. So when somebody is washing their hands in the hospital, the camera is watching them, and then this camera or the diode, which is controlled by an app, converts whatever the hardware has recorded into a software and gives you an immediate result with your compliance. So hand hygiene, I will be going through two types of devices that we have. The set of devices that I'll be talking about first are the ones that monitor our hand hygiene compliance by monitoring our steps of hand hygiene and how well we have washed our hands. So for that, we have a lot of tools available. These are the few important ones: the HAI Genie Soapy Pro hand washing system and the DevNet hand hygiene compliance monitoring system. Most of them use the same technology. How? So the first, I will tell you about the HAI Genie, which is called Vajra Hands. This has been developed by a Delhi-based company and it has been used in a few hospitals in Madhya Pradesh, where if you look here, you have So you have a device with a camera which is set up on top of the sink where the hand washing is done. When the hand washing is done, the camera is recording the steps that are being done by the hand healthcare worker, and immediately through an app you get, and even on the screen you get what was your compliance with the hand hygiene. A similar version that is being used in the West is the Soapy Pro hand washing system, which works on the similar principle, and the only difference is here the Soapy Pro machine also prompts the next step of hand hygiene that needs to be performed by the healthcare worker. Hence, it is also an educative tool as to what next they are going to do. Okay, next I come to Internet of Things based technology hand hygiene monitoring. What is Internet of Things? Internet of Things is nothing but a lot of devices which are physically placed somewhere, connected to the internet, and these devices can communicate with other devices. We use them in our homes daily. We all have Alexa and things. We have smart devices now. We have smart lights, we have smart fans. So they are all Internet of Things. Now how we are going to use this technology of Internet of Things and monitoring hand hygiene and how it's going to help us. Till now, I showed you the platforms where we see steps of hand hygiene. But how are we going to monitor if all the movements of hand hygiene are being complied with. Internet of Things is here. So what does it do? We have a lot of devices. We have sensors which are placed. Then the first thing is the sensors which are placed. Then we have wearable devices, which can be an ID card, can be a watch or a wristband that the healthcare workers needs to wear. All the data from these two devices is transferred to the cloud platform and then it translates to the user interface. How it works? Now this is the entrance of the ICU, which has a sensor placed here, and the healthcare is wearing a wearable device. If you walk past the sensor without sanitizing your hands, this sensor will detect that you have done that, and it will send an alarm to your device, as well as it will send a signal to the dispenser to dispense sanitizer. So the healthcare worker is motivated to go back and do his hand hygiene before he enters or exits the room. Using this technology, we have a lot of FDA-approved systems: the BioVision hand hygiene system, IntelliGuard hand hygiene monitoring system, and hand hygiene monitoring system by Clear Hands. To avoid being repetitive, as most of them work on the same principle, I'll just tell you about the BioVision. So now this is how BioVision works. This is a badge which the healthcare workers, when they enter the hospital, they collect this badge. They are always wearing this badge. And as they enter the room, you can see there is a sensor that is placed here that senses that the healthcare worker has entered the room. And this device prompts you to wash your hands. And it will give you a color. Green is clean, yellow is a reminder to hand wash, and red is to stop and do your hand hygiene in case you have forgotten. So in this way, we are able to manage both monitoring of the movement and monitoring of the steps of hand hygiene. There have been studies to evaluate how this works, and if you look at the study performed by Su et al., they notice that after using IoT-based technology, the compliance with hand hygiene rose remarkably, and it had a statistically significant improvement in hand hygiene. When they translated it to how it would prevent infection control, it would prevent HAI rates, even they said that it would be about a 5 to 25% reduction based on the area where the technology is being used. But even a 5% reduction would mean freeing up about 389 bed days out of 7,800 odd bed days, which would be a remarkable achievement in the field of prevention of HAIs. So this was what artificial intelligence has done with our hand hygiene. Moving to a predictive surveillance of HAIs that we are doing day and night to help our patients. When traditionally a patient comes into the hospital, after the admission, we start our surveillance, we start monitoring their parameters, and after the patient has an infection or probably shows a first symptom or a first test positive, we identify that this person has an HAI. As we use artificial intelligence, what we can do is, we can predict and we can see if a patient is at a higher risk of developing an HAI as soon as they enter the hospital. This model is called forecasting. Now we have started forecasting HAIs. So, before I go into how the machine models and the forecasting that we have done, I'll just run you through the common words that I'm going to be using. These are the common machine learning models that have been used in HAI: the random forest, logistic regression, the SVMs, the gradient boost, the neural networks that Sir told us about, and cross-validation. How each of these studies work is, like Sir said, we have to train and retrain. So our data set undergoes pre-processing. We train the machine learning algorithm, we create a model, and this machine learning algorithm then uses the data to predict. This data and its errors are again used to teach the machine learning algorithm to do better the next time. So we learn from the errors of the machine as well. We will start with machine learning in ventilator-associated pneumonias. So here, Gandhi et al., they said they thought that they wanted to predict VAP before it actually happens, and they thought that they should use a machine learning model to find what this prediction gap can be. So they used a lot of of patient data. This is the main important events that they use. The data was fed into a gradient boost, XGBoost model. That was the machine learning model that they used. And they found that when they used all the data, including demographics, vitals, labs, the ventilator settings, and the ventilator associated events, they could predict VAP at the prediction gap of just 24 hours post-intubation. So, this was a major achievement in shortening or even predicting which patient would get VAP before. There are more studies. Now that they know that machine learning is able to predict VAP earlier, they tried to work on which model would be the best. So now we have a lot of studies which compare different machine learning models to see which one performs the best. So Wakad et al., they used random forest, XGA boost and area boost and found that the random forest was best with an area, a perfect area under the curve usually of 1. Wakad et al. Compared this random forest with other traditionally used CPIS-based model and found a very good sensitivity and specificity, and it had an improvement of about 15% from what CPIS-based model could predict. Another technology that has been utilized in predicting VAP is the Cyrenose 320. This is an electronic nose or an e-nose. This has a lot of sensors which, based on the gases that are expired, produces a graph like this. So this baseline, if we see, this is the baseline of the ambient air of the ICU which is being fed into the e-nose, and this is the sample response, that is the breath of a patient that is being fed. Now this graph is analyzed by its software, the MATLAB software, and that software analysis was used in 2 machine learning models, the ENN and the SPM, to predict HAI, and the ENN network was much superior to the SPM. So today, if we start using machine learning, there is a possibility that even before the first event of the ventilator-associated pneumonia occurs, we could predict it. I would next move to the CLABSIs, which is very important here. Rahmani et al., they took the data from about 27,000 odd patients. They fed their data, including demographics, vitals, and they compared 3 machine learning models, the gradient boost, logistic regression, and the random forest models, and they found that the gradient boost model performed best with an area under a curve of 7.6. Another group of researchers, they wanted to predict an impending CLABSI in an ICU, and they took different patient level risk factors, encounter level risk factors, their demographics, their vital signs, and laboratory values, and they used 3 different machine learning models to process this data, and they found that they could predict 25% of the impending CLABSIs with a false positivity rate of 1. So in a 30-bedded ICU, if we use this model for 30 days, we could predict 25% of the patients who are going to develop a CLABSI, and we would have only one false positive. The 25% could be made 40% if we are ready to compromise with the false positivity rate. Next, moving on to SSIs. SSIs have so many factors that need to be considered: pre-op, intra-op, post-op, antibiotics, and the patient factors, multitude of factors. And SSI prevention is based on data from all these factors. So, for SSI prevention, there have been many platforms which are already in use from about 2016 itself. It started with the University of Iowa, who started using a high-definition care platform for surveillance of their HAIs, and they noticed a reduction of 74% in their SSI rate over 3 years. Following this, this DASH analytical system, it works with integrating the electronic health records along with the WHO safety checklist, and it inputs all these data into the models and identifies the potential risk, enabling targeted treatments to patients who specially need them. Following this, CDC started the Epicenter trial, which was a trial to evaluate how negative pressure dressings would impact SSIs. Now, for surveillance of these SSIs, they use the same dash analytics model, which analyzed all the data of the patients and during the surgery time could tell the surgeons as to which patient is at risk of developing HAI and whether the patient needed a negative pressure dressing or not. So AI is helping us in making decisions in real time. SSI surveillance is a burden to all surveillance is a burden to HIT to reduce the burden of going through so many charts. Chu et al. Used machine learning model and they found that if machine learning is used, we can reduce the rate of living charts by 83.9%, which is so significant. If we are using a machine learning model, we need not review so many charts just for routine surveillance of SSIs. There was another study where in spinal surgeries, Wu et al., they used now comparing 9 different machine learning models for predicting every type of SSI, all types of SSIs, including superficial, deep, and organ space. And the most promising that they found in their study was the XT boost model, which detects a complex SSI with an area under a curve of 0.9. This talk would be incomplete if I wouldn't tell how AI helps our fellow clinicians. The study here, they used 4 different machine learning models to find out which were the important risk factors that they need to look for in a patient, which predict the risk of this patient developing SSIs. So they use these 4 machine learning models, and if you look at the intersection, all the 4 machine learning models agreed on 4 risk factors, which were the modic changes from the MRI, the sebum thickness, the hemoglobin, and the glucose of the patient. So this model links these 4 risk factors to 85% of the SSIs. To conclude, whether it be hand washing, whether it be prevention of hospital-associated infections, reducing administrative burdens and costs, AI is here. AI is here to stay. AI is here to assist but not dictate. So let's start optimally using AI in our infection prevention. Thank you.
Thank you, Dr. Archa. Now I call upon Dr. Rahul from AIIMS Bibinagar to talk on antimicrobial stewardship. Archa.
So, good morning all. As the stage is set for AIML, I will be taking you through the major perspective of antimicrobial stewardship, how the machine learning will be beneficial for us, especially for our country, where we have huge data but we don't know what to do with that data set. So, in the outline, I will be taking you what are the antimicrobial stewardship interventions which will be beneficial from the machine learning, what are the machine learning applications which will be supporting for these interventions, and what are the inter gaps for using this machine learning in us. So if we see the published literature from 2004 to 2023, there is a huge published literature for related to artificial intelligence and machine learning in the science. And if you see the infectious diseases literature, and for that perspective the antimicrobial stewardship literature, only the 15 perspective literatures was there, and most of them were the respiratory data which were there. So we all know the core elements of antimicrobial stewardship, which is given by the CDC, the 7 core elements. So here, where all can the machine learning will be beneficial? It will be most beneficial while tracking these data sets which will be there and having that action in terms of prospective feedbacks or empirical therapy which will be there. So for next 10 to 15 minutes, I will be taking through the 6 scenarios which will be the interventions which we do in our routine practices for the antimicrobial stewardship, starting from predicting the antimicrobial resistance. So we all know that in our routine diagnostics, there is a major limitations which are there for the priority pathogens. In terms of the surveillance, we don't have much of data in terms of the genomics or phenotypic relationships which are there. So how machine learning is useful in that? Now people are working on integrating this genotypic and phenotypic data into a data set which will be there and putting that data sheets to the various algorithms which are there, as the previous speaker has told, various algorithms, and then train this data to predict the AMR perspective which will be there. So in that, first most of the people are working on training these data sets and then taking it further for testing these data sets to have the interlink between the genotypic and phenotypic relationship and how it can predict the antimicrobial resistance. So one of the very peculiar study which have taken a lot of data set from the US has been done for the non-typhoidal salmonella, where they have used 4,500 genomes, predicting the machine learning, how the machine learning models can predict for the 15 antibiotics which are there. And you can see on the this side there is a heat map which is there, where you can see in the light yellow or green there is the accuracy which is defined. So the light yellow and green are the most accurate, while the red are the least accurate, or there is the major errors which are there. The most of this study has told that the accuracy for the interrelation between the genotypic and phenotypic was as accurate as 95%, which is this data set was given. So now taking forward to optimizing the antimicrobial selection. So we all know that antimicrobial selection for the empirical therapy is not so much easy. We have to go through the whole pathway. What is the infectious diseases? First we have to think about it. Then what can be the likely pathogens? Then what is our local antibiogram tells about that? And then we are choosing the empirical therapy in our routine practices. So how machine learning can help in this? They can integrate all these data sets through the clinical diseases support system which will be there. So all these data sets will be fed in an electronic health records which will be there. The past history, what the antibiotics patient has taken, any risk factor which is there, what is the age of the patient, whether it is pediatric or adult or elder patient, and taking these all the data set to this clinical support system which will be there, and then taking these to further to the model which is there, the random forest per se, and then selecting which can be the appropriate empirical therapy for the patients. So again, one of the study which I told regarding this have been done from the US only. They have taken used data from around 14,000 patient data they have taken from last 7 years, and they have trained the model for this data for basically 3 models, as you can see in the screen. The logistic regression, the decision tree, and random forest. This data set was there basically for 4 antibiotics for the uncomplicated UTI which will be there. And then they have seen this data set for the optimal model which can be best for taking these data which will be there. So again, after seeing that, they have again retrained the data for whole 7 years, and they have just optimized the threshold between that phenotypes and choose the best treatment which can be there, and how this best treatment has been given by the physician as a part of the inappropriate antimicrobial therapy. They have just calculated based on various guidelines, based on various physician own perspective, and based on the algorithm. So what they have found, that is major chunk, that 71% reduction can be done on the broad spectrum antibiotics, and 16% reduction on the inappropriate antimicrobial therapy can be done if we are using these type of models in our routine practices. So now taking forward again to the predicting infection outcomes which can be there. So for us, the major mortality is because of the bloodstream infections or the sepsis which is there, and now how the machine learning can help in this is again integrating the data into the health records which will be there. Using this clinical disease support system, and then predicting whether the BSI is there or not there. So one of the studies done from the Willow, so they have taken around 10 years of data on various bloodstream infections, the suspected bloodstream infections which are coming to the emergency. They have created a huge database. They did the data mining on perspective, as the previous speaker has told, regarding the good data which should be there, and then they process the data. Then they have trained this data on various algorithms based on how to predict within the low risk, moderate risk, and the high risk for the bloodstream infections. They developed a model, retrained it, and take a threshold under which these risks can be appropriated. Then after this, they have done the validation for next 1 year, taking this data set and applied in the model, and now they are using in their institute for predicting the bloodstream infections as a low, moderate, or severe sepsis which will be there. So here you can see on the screen, the negative predictive value was 82% using this model, and the percentage of bloodstream infections in the emergency as soon as the patient is coming, they have the data set and the machine learning has told that 84% can be predicted at that time only. Now, talking about enhancing dose optimization, so we are always as a microbiologist feared for how can we tell the clinicians regarding the dose optimization which will be there. So for that, conventionally which is used is the conventional therapeutic dose monitoring systems which are there. So if we go through the conventional dose, therapeutic dose monitoring system, what we have to do, as soon as the patient takes the antibiotic, after that we have to wait for the steady state. Basically it is 3 to 5 half-life cycles of the antibiotic. Then we have to take the sample, that is the trough ratio we have to calculate. Then we have to measure it through the various instruments like HPLC. Then according to that, it will give the target range which will be there. And we will tell that according to that target range, it is under the therapeutic index or it is out of the therapeutic index. So this is the conventionally done. Now we will see how machine learning can help in this data set. So there is something called as the model informed precision dosing. Now here what we have to do, already the machine based on the patient characteristic epidemiological data and the clinical data of the patient, whether the patient is adult or child or a neonate, what risk factors the patient is, all will be fed to this various softwares which will be there, and then the sampling can be done anytime. We don't have to wait for the 5 half-life cycle to complete at that time. And then we don't have to wait again for the measurement of the drug concentration. It all will be loaded to the data set which will be there based on the software, and it will be calculated using the Bayesian estimations of PK or the target based population analysis can be done. And then the dose optimization can be done. So if we just take both into consideration, so in the conventional data set TDM, we have to go through the guidelines first, and then we have to wait for the steady state, we have to take the sample, while in model predicted, we don't have to wait of such, that can be done. So the calculation will be easy and effective during the first dose only. We don't have to wait for the steady state, we don't have to take the time sample that we have to wait, and the single sample can provide the whole PK curve that can be there, which will be beneficial for giving these therapies. So for this, there are various software tools which are available. Most commonly used tool is the DoseMe tool, which is used with various institutes. It again works on the Bayesian modeling, and it covers a huge coverage of drugs which can be there in this software which is enabled, and that is the benefit is the platform, both it gives the cloud platform and the dataset platform integrated in that. Now taking to the prediction of the infection risk which is there. So whenever we talk about the infection risk, we always go for the sepsis first. Sepsis, we know that it is a complex immunocompromising process, and the most important thing while dealing with sepsis is the early prediction of the sepsis which can be done. Taking distinguishing the sepsis from the disease states like inflammation, which can again present with the same signs and symptoms which can be there. So, if you see in this diagram, we have just take the inflammation, we have to just exclude the inflammation if you take the infection part, which can be predicted as early in the sepsis. Now, how machine learning is helping in this? Again, the machine learning, we have to feed the data, the structured and unstructured data. There is some diagnostic algorithms which are there, which I will go through, and then it will predict whether the patient is having sepsis or not in the early stage or the golden hours which will be there. So one of the study which is ongoing regarding this is the personalized sepsis study, which is ongoing in the Europe, basically. They have taken the data from 5 different universities, the major universities having a big healthcare facilities, and the whole data, including the ICU, laboratory, clinical information, other data was feed into the data set. There is a cloud which is called the clinical data warehouse where it will be feeded, and then the machine learning based on various models which has been developed, it is reading these data set to predict the early predictions which will be there. This trial, the first result will come in January 2025. That will be very interesting to see. One of the study which is done from the Europe for the early prediction have shown that in the early hours, that is the 4 hours and 6 hours, the algorithm-based machine learning can predict the sepsis as early as around 86% that accuracy it can give. Now again, one of the tool which is developed and validated is the EPIC tool, which I was told yesterday also. So this is the EPIC sepsis model inpatient analytical tool which is there. It is done from the US, South Carolina. And what we have done, using this tool, this is actually the early sepsis monitoring scores which are there. So they have put the score of 5. And they have just seen well in the baseline period when this tool was not alerted to the physicians, and when this tool has been integrated in the data set, and they give the alert if the sepsis score is more than 5. So you can see in the last row, you can see how this has helped in decreasing the mortality. In the baseline it was 24.3%, and in the intervention period when it is giving alert to the physician, the mortality reduced to 15% per se. And overall, the reduction was 44% in the odds of sepsis-related mortality that was given. So what is the future in the sepsis which is there? Currently, we define sepsis as a suspected infection with a SOFA score of more than 2 and a septic shock with having lactate more than 2 and use of vasopressors which are there. So how machine learning in the near future can help us with soon we will be feeding all this data into our electronic media and the risk factors, the various parameters, vital parameters, the pathogen identification, the source which will be there, and the biomarkers which will be there. And then AI diagnosed sepsis X will be one of the tool which is being developed, that will be there. And then again, we have to reanalyze the patient, and if any dysfunction or any organ function is there, then that has to be fed in there. So now, in near future, again the sepsis definition is going to be changed related to the machine learning perspective. Now again, in the UTI, in our setup, we know how much urine tract infections we are getting. So how machine learning can help? It can help various integrating various biomarkers and the bacteriological diagnostic biomarkers, and these all data can be again fed into the machine learning platform, which will enhance the accuracy and the pattern recognitions which will be there. Coming to the last intervention which will be there, the facilitating the audits which we will do routinely. So how machine learning is helping in that? So again, one of the study from the US where they have retrospectively studied the inpatient antimicrobial orders and the patient characteristic in the antimicrobial stewardship interventions related to the prospective feedback. And here the algorithm which was used, the random forest algorithm which was used, and this has shown that these audits can be reduced with around 49% with a sensitivity of 78% which can be done using these tools which are there. Now again, the ChatGPT which we are using routinely now, so in that also antimicrobial stewardship has been feeded, and you can use in your routine practices also. There is something called a virtual antibiotic steward in ChatGPT formed by Mr. Blanford, which is there. So this is again one of the tool which is very helpful in day-to-day practice which is there that can be used. Now coming to the gaps or the challenges which are there. So major gap is the data quality, because all things depends on the data, how we are feeding the data, and there is huge integration which has to be done. The practical validation of these data is again one of the challenge, because most of the data sets are being revalidated in a retrospective format, but validation has to be done. The interpretability, transparency and trust for these sharing of data, the risk of error, patient harm, maintenance and cost is again has to be taken care. And now we need the machine learning and the human interface to go forward through these pragmatic trials to see how it can be helpful in various critical care setups. So the takeaway are, we have to build multi-center database, which is now again from Ministry also. This Digital Bharat Abhiyan has been initiated from Government of India, and by 2047 Ministry has also told that we have to channelize machine learning platforms in the healthcare setups. We have to continuously work on the model trainings, which you have to done continuously, and see which model is working appropriately in our health setup. We have to implement science for the optimization of the therapy using various dose optimization tools which are there, where the machine learning has been fed up. And again, human AI interface studies has to be done, and basically the tools which can be used for the clinical disease support system has to be developed. Thank you.
Thank you, Rahul. Please have a seat. Next, I invite Dr. Priyadarshini from St. John's Medical College to share information related to artificial intelligence and fungal diagnosis.
Good morning, one and all. So this is how probably our future labs will look like, and I will be talking about the applications of AI for fungal infections. Now there are 5 rather success stories or ways in which AI have been used for fungal infections, and I will be talking about these. Direct detection of fungi from specimens, identification of yeast from imaging studies and the byproducts that they release, direct examination, detection of fungi by direct examination for keratitis and skin conditions, and also the identification of fungi by LPCB morphology, which to till date is the gold standard for identification of fungi from culture. So the direct detection of fungi from specimens. Now, what can AI models do? We know that till date, a preliminary KOH examination on the samples that are received in the lab for fungal diagnosis plays a key role in picking up these fungi. So AI models can analyze these KOH images. They can analyze the fungal culture images. They can also analyze the histopathological stats. So this was a study done by Hu et al. For automated detection of fungi from superficial specimens for diagnosis of fungal infections. So they simply did this. They took the KOH preparations. We all know that we often face difficulty when we have to give a KOH slide as positive or negative. We might miss the scanty hyphae. We might also many times have confusions regarding the nature of the hyphae. So this study group, what they did, they simply took the KOH slide, they recorded a video using the microscope of images under 40 and 100x. They converted the entire video into frame-by-frame images, and they trained the software called as the Willow V4. They fed it into the software, and this software was able to auto-detect the hyphae using something called as a bounding box. So you simply place the slide, and it will highlight the area where the fungal fragments are there. Of course, there are specimens from which it sort of did a false positive detection as well as the false negative detection. It had a sensitivity of 93.2% and specificity of 89%. It's a quick and convenient screening tool, but a large set of data from microbiology confirmed cases need to be fed it to actually pick up these hyphae. A similar thing has been used for histopathological image analysis as well. I know there are not a lot of studies in microbiology that we've seen when it comes to AI, but histopathology has used a lot of these AI tools for screening their slides. So this study group developed a tool for onychomycosis. They collected 528 nail samples. They did a whole slide digital imaging of these nail samples, which were stained with PAS stain for detecting the fungi. And a small image of size 256 and 256 pixels were given as the input. These slides were actually seen by 4 different experts, and the machine was asked to detect the hyphae from the samples, and it was able to detect these small patches labeled there as 1, 2, 3, 4, 5. And what did the machine do? It could actually pick up 11 more of those scanty fungal fragments which the histopathologists had actually mixed. And they went back to these slides and they actually picked up these hyphae as well after careful examination. So what can all of this do? This can reduce the time we take to screen these slides and also improve the sensitivity. So in histopathology, there is also often confusion regarding the nature of hyphae, because we all know that these tissue sections are taken at different planes, and when they are stained for with special stains for the detection of hyphae, there is often confusion. So this study group developed a very nice tool for differentiating between the aspergillus and the mucor. So the pitch they used was this. They took 147 septate sample images and 67 aseptate sample images. These were all PCR confirmed cases. So they measured the crossing angles of the hyphae and also the folding and the tortuosity, which is more enhanced with mucorates. And they developed an algorithm to actually differentiate between the aspergillus and the mucor. And we all know the importance of detecting the mucorate in a given tissue sample. It really impacts the management. Coming to the identification of yeast by imaging and the byproducts that are released, we all know that the conventional methods take time, at least 2 days, to grow the organism and identify it by either TipTop or other automated methods or biochemical tests. What can AI do? So AI can actually directly give you a species level identification based on a simple gram-stain image. I know it all sounds very not okay, because we as microbiologists want it to be confirmed till the sequencing level to call it a particular fungus. But this study group created a database from the gram-stain specimens of 9 strains that they had. They took multiple images. Now it's not okay to just put in one image of a slide and then train this software to say that this is Candida albicans. So what they did is this. The 9 strains into 2 preparations, into 10 of those replicate images were fed in. And they used this deep bag of words algorithm. Now machine learning algorithms have been extensively used, and the CNN, AIAMM, all of those modules have been extensively used. So these people took it a step ahead. They used a multi-step algorithm where it pools the different point images to classify it into a particular species. So this was what it came with. A standard set of parameters to describe the species based on the size, shape, arrangement, etc. And it will create a matrix like this, which the machine can use to identify the species just from the gram-stain. And this is something which many of the imaging studies use. It's called as a qualitative confusion matrix. It's a misnomer, I would say. It doesn't actually confuse you. It's like a 2x2 table with the predicted label on one axis and the true label on another axis, and it will tell you the probability with which a particular species can be either identified correctly or maybe mislabeled. Going on to some more techniques which people have explored, we all know about Moderator. This is a similar technique, not in terms of ionization and the spectral formation, but this is a single cell Raman spectroscopy. So this technique uses a laser beam which falls onto the cells. This is done using the Raman spectrometer, and once the cells, the vibrational properties of these cells are captured in the form of a spectrum, actually used 94 clinical isolates of Candida with 1 lakh spectral images that were processed. And these spectral data told us what the species of Candida was. And this identification can be done within 60 minutes. They also tried it on biological samples directly because it's a microscopic technique that is done. And the accuracy was almost 100% as compared to Martikov with all the clinical isolates. And it was also to a very great extent differentiate between bacteria from yeast as the first step, and then it moved on to tell that which species of yeast it belonged to. E-nose, the previous speakers have also told about this. So E-nose combined with time series based classification techniques can be used where volatile organic compounds released by these culture plates, which are grown on simple saccharose dextrose agar, is fed into a machine which looks like this. It's called as an E-nose machine. And the fingerprint, the smell fingerprint is generated, which will help to accurately, with an accuracy of 97% to identify these fungi. These have been used for some of the filamentous fungi as well. Coming to the LPCB morphology of fungal culture isolates. The LPCB morphology, once the fungi has correlated, it tells us which species it is. So what can AI do? Identification using something called a CNN, which has already been discussed before. So this is the set of input images that were fed in this study. They used about 89 fungal species, the LPCB mounts of all these species. Remember that to use all of these modules, we need high definition cameras which can take very good pictures of these slides and then use the machine learning to train the machine to do the identification. Of course, I mean, this is not possible with non-correlating fungi, where we still have to rely on alternative methods. So once the data is fed in, the machine reads and using the different pooling layers, identifies it to the species level. They also did something called as a saliency map, which is again being used extensively now. Basically, what is this? The training is augmented by making transformations to the picture, simply by rotating it, sharing it, making it left to right, and with all this the machine should be able to identify what it is, what fungi it is. So they did this robust technique to improve upon the identification. So identification, once the fungi has grown in culture, can be by the supervised learning task driven approach, which I described just now, where you have a manual annotation for the known images and a generalized training data set, which the machine will compare it with and give the identification. You can also have an unsupervised learning technique where it will classify it into just clusters like Propylium, Eukaryote, and Aspergillus and Candida, and not really the exact species. And the most relevant and the most which comes closest to how we humans work probably is reinforcement training, where it is based on trial and error. There is a self-improving algorithm. Positive results are rewarded, and there are punishments for negative results, and the machine constantly learns. So the OpenAI platforms, to just check how this OpenAI platform works, I just uploaded an image, LPCB image onto ChatGPT, and yes, it did correctly identify it as Chlamydia bolus, but these platforms are to be used with caution. The results have to be taken with a pinch of salt, because this needs confirmation and it's not 100% accurate. So there are several study groups, at least not from India, but from Singapore, which I came across, where they have collected about 8,500 images spanning over over almost a decade, and they have developed this database to identify the fungi using CNNs and vision transformers, and they've reduced the TAT in their own center. They've made a local database. It's possible for all of us to do this with the images that we already have, and we can do this. So we are going on saying that the machine has to learn and learn and learn, and probably we'll see this someday when the machine also gets tired. Detection of fungi by direct examination. So now this is an in vivo method, a bedside method, where the diagnosis can be done using the slit lamp biomicroscope. Ophthalmologists use this in the OPD for examining the cornea. The different types of microorganisms produce different types of infiltrates in the cornea, and we all know that. So a slit lamp biomicroscope examination was done, and the data was fed in. And they used 3 networks First, to differentiate healthy cornea from keratitis. Second, to differentiate bacterial from fungal keratitis. And third, to differentiate Aspergillus or Fusarium from Candida species. So this was the accuracy represented here in percentages. And of course, these were microbiologically confirmed cases, but they did not have a very large data set that they used. They had about 500 images overall, including bacterial, fungal, as well as the healthy cornea pictures. Confocal microscopy is again another feature which can be used. This has better resolution than slit lamp biomicroscopy, where the ophthalmologist sits, examines the eye of the patient, and the image comes on to the monitor that is attached. And you can see here that the acanthamoeba cysts can be picked up, the fungal hyphae can be picked up, non-specific keratitis with inflammatory cells, as well as the healthy cornea. So they took about 4,000 in vivo confocal microscopy images over a period of 10 years from IAIMS records, and they fed it into the system to pick up these different pathogens, and it was able to do it with an accuracy of 93.5%. This is also possible for superficial fungal infections. Dermoscopy is a technique used where it helps in the visualization of the different changes in the skin in the appendages using a dermoscopic instrument which is shown here. So what can the AI models do? So these are the pictures which were taken with high resolution of the different nail changes in the onychomycosis cases. So the dermoscopic images were fed in and the data was given, and it was able to pick up these and say, yes, this is keratitis caused by fungi. This is probably a non-specific kind of onychomycosis caused. The fungal agent is the infecting agent, and it also was able to bypass probably the processing of specimens in the lab just to start at least the empirical antifungals in these set of patients. Even during the COVID times, these were tested out, and the group tested the photographic image acquisition of normal and diseased eye, did a feature extraction and classified using a confusion matrix to pick up COVID-19 associated mucormycosis from remote settings. So you can have an image uploaded from probably a village where you're sitting, and then send it to the AI-based apps or platforms that people have developed, and it can give you a probability index, and it can tell you that this is this condition. These are the different pros and cons. Of course, we've talked a lot about AI today, but there are some things which we have not probably dwelt on today, which is of course a big topic for discussion: the ethical considerations, the privacy, the compliance maintenance, the complexity, and of course the confidentiality of our patients. So this needs to be dealt with in detail, and AI needs to be used with caution. So these are my references and acknowledgements. Thank you all.
Thank you, Priyadarshini. And next I would like to invite Shripad, who has done work on artificial intelligence, the rapid test. I would like him to share for a few minutes. With that, we will end the session.
I know I've got time constraint, but being assessing just the rapid test, I will be rapid in my presentation as well. The laptop is not ready to listen to all the AI stuff. I think it was locked. So we need the expert. Okay. So with the base of what AI can do to us, let's get back to the basics. What almost 30% of our work is going on. Most of us are reporting rapid tests. These rapid tests have been interpreted by the junior residents, the senior residents, to the teachers themselves. So what we have developed as a startup is a AI-based tool which can, or an app, which can scan this rapid test. So I have a data of almost just 30 tests, and I would share how it works. It's a simple scan and use app which can be integrated with the LIS system. That's the next function which is going on. So basically it started with how do we document this rapid test which we are using in our laboratory on daily basis. Let's say in our emergency at the Sion Hospital, the malaria, leptospira, dengue are diagnosed with the help of rapid test in the emergency lab. So without just going through the applications, so this is what we are using rapid test for. Most of the labs are using, and the rapid tests are also used for biomarkers, which has come up as a new thing. So the documentation of this rapid test becomes crucial. It could be a statutory requirement for accreditation purposes and as a record for future reference. And as it is said, anything which is not documented is not done. So it is an app named RapidScan, which helps in identifying the test, which can identify the patient from the LIS system which is there, or it can have its own integrated app based where you can enter the patient, which will be used for the regulatory purpose, also for the reporting purposes. Because the documentation which we use is a time consuming, there can be error, like transcription error, and there's major problem in data retrieval in such cases, which leads to waiting and high workload, which is a challenge, and inefficient data management. Automation with the help of this type of apps is app thing. So this is the app which has been developed by our startup, which we can have a patient entry, or it can be integrated with the LIS system as well. We can also manage the inventory of this rapid system, the rapid tests. We can select the different tests and add on new tests as per our requirement. Any make, any company, anything we can do it, and just use the button as scan and run the test. And it gives the results by scanning the report, scanning the image by the technologies which was described by my previous speakers. It collects the data, and you can also have the reporting format to the same app which is available. You can also search the data or transfer that data to an Excel sheet for further analysis. So during this first initial phase, we did 50 samples on this particular app. We even diluted some strong positive samples tenfold time and then ran on it. Now, I don't know if you can see the picture over here. You can identify the last cassette, which has got a faint band. This was also picked up by, in the tenfold dilution was picked up by the app, which was later confirmed by LIS and clear-based techniques. So this kind of app, which is an indigenous, which we have developed, can be useful in reducing errors as time saving and also enhance data management. The data can be stored on cloud. It is user-friendly interface, and the scanning is AI-driven, which would help all the stakeholders like healthcare professionals, patients as well as administrators. The next line what we are doing is further integration with LIS, so it can detect even the barcodes which have been generated by our LIS system. We can have enhanced analysis and correlating with the other test results, and quantification will also be tried in the next level. Also for surveillance purposes, we are working on it for geo-tagging, so that we can identify the hotspots of the diseases like malaria, dengue, and this would be useful or even seen directly by the epidemiological survey unit or the unit which is responsible for preventive maintenance. So that's all I think I was fast enough as said by Taklikar sir, and I would like to thank Taklikar sir and Balaji sir for giving me this opportunity to present now. Thank you very much.
We are not taking any questions. We are running out of time. I would like to once again thank the IAMM organizers to giving us an opportunity to present on AI on various aspects, update. So once again, I would like to thank Dr. Pragya Agarwala, Dr. Sharma, Dr. Rahul, and Dr. Priyadarshini for making an effort to gather all the information which has been in the public domain on utilization of this AI to improve the patient care and laboratory diagnosis. With that, I would like to thank you all. Thank you very much.
Thank you so much, sir. I would like to request Dr. Balaji to please give a token of appreciation from IAM to all the